session. Moving on to the next session, I would like to invite our next speaker, Dr. Sudeep Das. Dr. Sudeep Das is already online, has switched on his camera already. So over to you, sir. Request you to please unmute your lines.
Thank you so much. Welcome to this session on basically managing catastrophes during intraocular surgery. We are supposed to have a guest lecture from Dr. Bilal Hussain. Is that ready?
Yes, sir. Hello, sir. I am ready, sir.
Yeah, welcome, Dr. Bilal Hussain. He'll be speaking on the keynote address is on capsular tension ring, usefulness of lifeboat in sinking situations.
Thank you so much.
Please go ahead.
Sure, sir.
Your audio is not very clear.
Sorry, sir. Just to share my screen. Sorry, is it visible, sir?
Yes.
Okay, sir. I am proceeding, sir. So, respected chairperson, dear colleagues and audience, I welcome you all our today's presentation. I am Dr. Bilal Hussain, vitreoretinal surgeon in Combat Military Hospital, Dhaka and Bangladesh Eye Hospital, Uttara. So I am very much grateful to All India Ophthalmological Society for inviting me as guest faculty to share our experiences. So I will share today with you all regarding capsular tension ring, the use of lifeboat in a sinking situation. And I have no financial interest to disclose. So capsular tension ring is an essential device in case of cataract surgery with zonular dehiscence. And CTR may help to prevent further subluxation, even dislocation of IOL after insertion. But proper handling of CTR is very important to get utmost result. So timing of the CTR is very important. So it is wise to implant CTR as early as possible, just after detecting the zonular dehiscence or a decision of the insertion. So first, we separate the anterior capsule from the remnant of the cortical matter, and through the with the help of instrument, we insert the CTR, which gives better capsular support, while for vacuum also. In some cases, CTR may be important to insert at the middle part of the surgery. So in this black cataract, you have seen after doing vacuum of few portions, then zonular dehiscence was detected, and then we decide to implant CTR at the middle of the surgery. But even after sometimes in few cases that there may be trace amount of zonular dehiscence, and with those you can complete the capsular axis vacuum even IOL implantation. But to ensure the security of exact position of the IOL in back, you may need to insert CTR at the end of the surgery also. So, very frequently we found few cases of coloboma with the cataract, and CTR is one of the prime tool in management of cataract surgery with coloboma. And if the amount of dehiscence is very much or huge is the amount, so along with the CTR, sometimes we need to implant CTR segment also for better stabilization of the capsular bag with IOL. So in such cases, CTR segment also gives better result. So technique of implantation of the CTR. So it is very easily possible in case of when there is a nucleus inside the bag. But implantation of CTR in aphakic cases actually a bit difficult due to lack of support in the capsular bag which usually we get through the cortical matter or nucleus also. Even in some cases, the CTR may land in unexpected position also. And from such kind of position, it is very important to safely rescue the misplaced CTR. And improper handling may give few complications like hemorrhage, iridodialysis, even iris damage also. So for easy and safe removal of the CTR, a second instrument is very essential. So first identify the shaft to remove the CTR in a misplaced position. And you can take help from the second instrument and give a support under the CTR to easily remove this from the misplaced position. Though sometimes it may be possible to implant the CTR again in the capsular bag, but we can remove it also. So after removal, so we will implant CTR in a easy way. So first guide the head leading part of the CTR with a second instrument, then put it and keep the shaft supported within the second instrument, and then put it within the capsular bag. Sometimes after doing a eventful or uneventful cataract surgery smoothly, CTR may be needed after the IOL implantation also. In this case, you have seen there is an inadvertent pulling of capsular bag while doing IA. So there is a instant development of zonular dehiscence. So in such cases, we also may implant CTR for better capsular support. So when there is a zonular dehiscence at excess amount about more than 180 or 180 degree, then along with the CTR, for doing the phacoemulsification or intraocular others procedure in cataract surgery, we may need help from the capsular hook. So capsular hook usually gives better strength to the bag, which helps to do further procedure smoothly. And in such cases, sometimes we also use capsular segment for better stabilization. After implantation of CTR, sometimes removal of the remnant of the cortical matter becomes a bit difficult. So it is very important to remove all the cortical matter. So in such cases, what we can do, we can remove the cortical matter along the guidance of the shaft of the CTR, just pulling the cortical matter through the open portion of the loop of the CTR. And ultimately, this gives any cortical matter free capsular bag and smooth surgery. Sometimes there are few cases where there is a corneal opacity due to trauma, even anterior capsular fibrosis. Sometimes this traumatic cataract may develop with the may present with the some amount of zonular dehiscence. So it is very important to go for CTR in such cases. But due to poor view, CTR may land in an unexpected position also. So previously I have shown how to remove a CTR, then re-implant it. But we can also reposition a CTR within the capsular bag in the same CTR at the same setting also. So CTR is a very essential device for a smooth cataract surgery and fruitful cataract surgery in case of cataract with zonular dehiscence, and it is a lifeboat in a sinking situation of a capsular bed. And proper insertion can make optimum safe position of the IOL, but improper handling can cause iris damage and hemorrhage. So pre-operative proper evaluation and meticulous operative handling can give the optimum output result in case of CTR implantation in cataract surgery with zonular dehiscence. Thank you so much, sir.
Sudeep, you are muted. Sudeep, you are muted.
Yeah, now we can hear you. Yeah.
Dr. Bilal, that was a wonderful presentation, a very comprehensive one on use of CTRs. I'll request you to unshare your screen. Thank you. Welcome to this session we've been having for a few years now on intraoperative emergencies in cataract surgery. And this time, of course, it's virtual. So we have with us a cast of eminent speakers. We have Dr. I'll be speaking on PCREN in not just premium IOL patients, because you have to master it in regular surgeries to do it perfectly in premium IOLs. Then Dr. Arup Chakrabarti will be speaking on intraoperative hard eyes of acute onset and incisional burn. Then Dr. Suvira Jain will be speaking on zonular dialysis and lens tilt during chopping. And Dr. Meenu Mathan will be speaking on PCR or zonular dialysis with IOL implantation. I don't think the wound burn is there in this. Sorry about that. It's got repeated twice. And then Dr. Suvan Bhattacharya will be speaking on rapid intraoperative meiosis and iris prolapse. And Dr. Suvendu Boral will be speaking on expulsive hemorrhage and suprachoroidal hemorrhage. So without much waste of time, I will start with my presentation on PCR in premium IOL patients. And the most important thing about PCR is to avoid it. Prevention is obviously better than cure, and there are many steps that can be taken to avoid PCR. One is to construct the wounds extremely well. A tight wound will cause AC collapse, so will a loose wound. A tight wound will constrict the irrigation, the sleeve, and the loose wound will cause leakage. So prevent these from happening, and always balance the fluid perfectly, so the inflow is always equal to outflow. You can always tweak it depending on the case. Adjust irrigation, aspiration flow rates, vacuum if there is any AC fluctuation. So for that to happen, you have to spend time to really understand phaco-dynamics. And you'll see a lot of senior surgeons using extremely high AFRs and vacuum 700, 70 AFR. Please don't use that unless you are a very extremely proficient surgeon. I still won't use it in my regular cases. So use reasonable bottle heights and IOPs. And again, don't reduce the IOP too much. Nowadays, you'll hear a lot of people talking about using extremely low IOPs and doing phaco. Again, it's not needed. And beginners need to reduce parameters while emulsifying the last fragment. The other thing is, when you're managing PCRs, take care to do it in all cases. You have to manage it perfectly with all cases, not just with premium IOLs. Work on preventing PCRs, learn the art of managing PCRs well, and you have to understand the principles of vitrectomy. And once you do this as a habit, it will become a breeze managing complications in premium IOLs. Otherwise, you'll be stuck. So precautions to take when you're noticing a PCR. First thing to do is do not just pull out all your irrigation, your phaco, handpiece, everything out of the eye. Do not shut the irrigation. Keep it inside the eye. Move from foot puzzle position 3 to 1. Keep it on irrigation. Shut off vacuum and phaco. Because when you shut off enlargement of the PCR. Inject OVD, whatever is available at hand, through a side port to stabilize the AC and push the vitreous phase back. Inject highly dispersive or retentive OVD if it's available. And the next step depends on when the PCR occurs. If it's right at the beginning of phacoemulsification, you cannot do a phaco, convert it to an SICS or even an ECC. If there's a small bit of nuclear bit left, you can do a phaco under OVD cover, block the PCR with OVD. And if there's a small vitreous bit with nucleus bit with vitreous in the AC, do vitrectomy and then phaco. And if there's cortex, again vitrectomy and then IA, and choose the appropriate IOL when necessary. It's not that you have to implant what was promised to the patient. It may not be practical. So this was a very brown cataract. It was supposed to be for a toric IOL. And as you can see, it's going reasonably well. And what happens in a lot of patients is that we relax after the phaco. And that's what happened here. There you can see I'm catching the vitreous. So I did the black cataract extremely well, but then I relaxed and was a little careless while doing the IA. So first thing to do is inject viscoelastic. Now I'm injecting Viscoat. No financial interest in that. Inject the IOL into the bag. There's no vitreous in the wound as yet. Whatever was there has got pushed back, but in case there is, I can always remove it after implanting the IOL. So there wasn't any, and the IOL is very much so this was a PPC. Again, everything has gone on well. I removed the nucleus and removing the epinucleus. I remove the cortex, and I do something which should not be done. You know, you're so sure sometimes. I just touch the PC because there's a small PC which won't even have affected the vision, and the PC is gone. So I keep the irrigation on. That's the most important step. Inject viscoelastic, and then convert that into a posterior capsular axis. So now you can see it's very much smaller than the anterior capsular axis. And it's very easy to tear because there's no zonules trying to pull it out. So once that is done, you can inject any IOL you want into the bag. So this is a multifocal. But remember that those tiny 0.5 millimeter PCOs are really not going to affect the vision of the patient at all. And this is a video I wanted to show, which is specifically on converting a PCR into a PCC. So you can see that if you see a tag, you can do it. If it's sort of roundish tear, you can't. So here is a tag. Do not inject too much of viscoelastic into the anterior chamber because it will push the PC back. So just inject enough to keep the vitreous face back. And just convert that into and it doesn't have to be very large, it can be quite small. And then you can inject any IOL if you want into the bag. So this is just the hydrophilic IOL, not a problem. This is something that I've done very, very recently, just 2 days back, absolutely black cataract. And everything seems to be going well. So I've done a trench and then actually got a complete crack even through the endonucleus. And when I took most of the nucleus, I realized that there is some bit which is here. So I thought, okay, fine, it's somewhere in the equatorial region. So I pulled that out, 2 big pieces, huge pieces. And again, emulsify that. and everything seems to be fine. The PC is pretty flat. And once that is gone, I see a hazy thing right here. And I realize it's behind the PC. And the PC is so flat, you won't even suspect that there's a PCR or a ZD. And look at the size of that. So managed to pull it out. And then I decided to implant an IOL. The PC is still very flat. I didn't want to, I think it's a small ZD, but since the rexus is very large, I can't implant a CTR. So I remove the bit and then realize that there's a bit of vitreous. So I do a vitrectomy and everything is fine. Patient was actually doing pretty well on the first post-op day. This is the last of all the cases. It's a huge PPC. When you see this, you know that you are going to have trouble. So while it's a very soft cataract, while removing the epinucleus, the PC gives way. Inject. This is just HPMC that I'm injecting to prevent these pieces from going down. I'm actually holding it still with vacuum because there was a piece stuck on the tip. Then I expel it out with viscoelastic. I do a proper vitrectomy. And then you can make out that the vitrectomy is done because the cortex is getting aspirated quite easily. And this is a 3-piece multifocal IOL. In these cases, you cannot put in a single-piece IOL into the bag. This 3-piece multifocal IOL, which can go into the sulcus, and you can do an optic capture. So this is where you tuck the optic behind the bag. So the haptics remain in this is where I'm tucking it into the bag. You can see this is the margin of the rexus. So coming to the take-home points, preventing a PCR is better than managing a PCR. And early detection is necessary to avoid the PCR from enlarging. Use dispersive OVD as a buffer between the PCR and nucleus pieces. And always try to convert a PCR into a posterior rexus wherever possible. And reduce flow parameters in presence of the PCR and use the appropriate IOL to prevent short-term and long-term complications. So thank you very much. Now I think we'll take the questions at the end of the session.
Can I start, Sudeep?
Yeah. The next talk is by Dr. Arup. Please go ahead.
So thank you, Sudeep, for inviting me for this very interesting course. I will be dealing with a couple of situations where, situations where the eye became quite hard during the course of the surgery. When we started off, everything was fine as far as the IOP was concerned, but at subsequent steps, at various steps, the eye becomes hard. So I'll be dealing with two such situations in my presentation today. Now, this was an elderly lady in the 60s, angle closure glaucoma on prostaglandin analogs. Pressure was well controlled. And if you see, if you just see here, when I make the inferior paracentesis, AC is a bit shallow. So my MVR tip, it touches the anterior capsule. There's a wrinkling. I don't rupture the anterior capsule. So I'm more careful when I do the superior paracentesis with the 20 gauge MVR blade. This patient had a normal intraocular pressure and with prostaglandin analogs. the anterior chamber depth is more than 2 millimeters. So my rule of thumb, till this case happened, this mishap happened, was to use IV mannitol pre-op only for angle closure glaucoma patients where the pressure is above the 20s or the anterior chamber is less than 2 millimeters. So now I use pre-op IV mannitol routinely for all my patients who had angle closure glaucoma with coexisting cataract. So you would have seen that it was quite difficult for me to inject in the intracameral xylocard. So I could have postponed the surgery for a later stage on a different day, to be taken up on a different day. But I thought I'll start IV mannitol very quick and run it in about 10 or 15 minutes. And in the process, the eye, I was expecting it to become soft. So I am really going slow here, hoping that the eye will become soft, and then I'll have a stable or a sufficient depth anterior chamber for me to perform the subsequent steps of phacoemulsification. Now, this patient did not have any altered fundus reflex, so there's no pain. And so suprachoroidal hemorrhage was ruled out, because if you suspect suprachoroidal hemorrhage, then you have no business to continue the surgery. The surgery has to be postponed by a couple of maybe 2 weeks or so, and along with the posterior segment surgeon, when the suprachoroidal heme is evacuated, once it is liquefied, and then the cataract surgery can be completed. But this particular patient had no such pain, or you can see a fantastic red reflex, and it does not progress as I had planned. The AC does not become deeper. Eye stays pretty hard. In fact, it becomes harder. So IV mannitol obviously is not working in this kind of situation. So I decided that I now have already done Rexis, postponing the situation. The case for a different setting may not really be very, perhaps a wise thing to do. So I decided to do a limited passband anterior vitrectomy using a 23 gauge self-sealing trocar cannula system. I would not advise a newcomer who has never, a young surgeon who has never done a surgery to the passband to straight away use this approach in similar complex situations. But you need some amount of training when doing passband anterior vitrectomy. So I did a little bit of vitrectomy. You can see the probe behind the lens and behind the cataract, and the eye has become pretty soft by I could make out that I have sufficiently soft anterior chamber in the intraocular pressure, and the anterior chamber is it is quite okay now. So I went ahead with cortical cleaving hydrodissection. As you'll see here, it was pretty uneventful. And then phacoemulsification was also, without any difficulty, it was achieved. And so let me fast forward through that, because there's nothing much to show here. So it is a cortical cleaving hydrodissection has gone off well. You can see the golden ring sign, hydrodelineation also has occurred. And then I injected a three-piece hydrophilic acrylic, single-piece hydrophilic acrylic into the capsular bag. So the patient went off pretty well. And the surgery, post-operatively also, the patient did extremely well. So I would not recommend aspirating vitreous using a needle in this kind of situations. So if you have to go through the passband, it has to be using the vitrector, using the technique that I've shown. So this patient did pretty well at the end of the day. Now this is the second case where I had similar problems. It was a male 63-year-old patient with multisystem illness. He had everything, all systemic illnesses. PDR with maculopathy, and he had received multiple injections of IV intravitreal bevacizumab. Grade 4 nuclear cataract. It's not. It is a routine cataract for most of us, and surgery is going up pretty well. But I have a Rexis about 5 millimeters in size. I'm not really anticipating any problem in this particular case. And at this stage, when I started doing cortical cleaving hydrodissection, I missed the pupillary snap. And this was seen only retrospectively when I reviewed the video. And we just see the snap that happened now. So what has happened is the fluid wave that has gone behind has moved the nucleus forwards, blocking the aqueous pathway. So more fluid collects behind the nucleus, and elderly people, the posterior capsule generally is fragile. So posterior capsule gives way and you get a pupillary snap. So now I realize that I have an issue, and what do I do? Now this patient was on renal dialysis, and it's very difficult for me to schedule him once again out of turn. So I decided to go ahead with phacoemulsification. So I thought I'll debulk the nucleus and then start chopping. At this stage, I realized that there was a little bit of nucleus tilt. And I decided to go ahead in spite of that, because nucleus tilt and lack of not smooth rotatability of the nucleus actually are quite ominous signs. You should think about converting from phaco to a non-phaco technique, safer technique. You don't want any of the nucleus to be going behind, and this is what happens here. See, the nucleus doesn't rotate. At this stage itself, perhaps I should have converted into an SICS. Then I did not do it because, this patient was quite uncooperative. He had pulmonary edema, and, converting to SICS may take a little longer time. So I thought I should be able to finish off the nucleus removal before anything untoward happens. And then the last chunk, it went behind. So I decided that, I'll not go ahead with IOL implantation right now. Patient last few minutes of the surgery was performed with great deal of difficulty. Patient was moving, trying to get up because he was uncomfortable because of the pulmonary edema. So I thought I'll just remove the vitreous from the anterior segment and remove the residual cortex, what as much as I could, mop up the anterior segment, and then leave the patient aphakic. So before I finished this case, I made sure there is no vitreous in the anterior chamber, and then I closed the incision with a nylon suture, as you see here. And last bit of suturing was happening, when the patient was almost getting up. So the patient was rescheduled for surgery. So he came back after a couple of days after the dialysis was done, and then we went through the pars plana to remove the small chunk of nucleus that was in the posterior segment. And that was done by the posterior segment surgeon. In the meantime, the pupil had become small. So I used iris hooks to dilate the pupil. You have to make sure that you do not catch the rhexis margin in this kind of situation. So I changed my plan now. I decided to use a 3-piece hydrophobic acrylic lens to be kept in the sulcus with an optic capture, posterior buttonhole of the nucleus of the optic. So make sure that the leading haptic goes into the ciliary sulcus. It should glide anterior to the anterior lens capsule. So this has to be done pretty carefully, and this is a technique of putting the trailing haptic in the sulcus, compression dialing. I don't dial the lens; I rather compress the haptic and then just bring it under within the pupillary margin under the iris and just release it here. So the lens is resting in the sulcus, and the optic is pushed behind the rhexis margin. And this is a very good mechanism to keep the lens locked in place. It is going to be well centered. You don't have to really alter the intraocular lens power. So I decided again before intracameral pilocarpine was used, and wanted to ensure that there is no vitreous at the end of the surgery. So this is very, very critical to make sure that there is no vitreous. And then this is the post-operative day. The patient has done quite well as far as the the vision is concerned. So you would have thought about infusion misdirection syndrome if there's no definite pupillary snap, and infusion misdirection may happen during faulty hydrodissection or during emulsification or during irrigation aspiration. But then I knew that it is a pupillary snap that had happened, and I broke the posterior capsule. Acute intraoperative rock hard eye syndrome also has been reported in JCRS from an Australian center, and which was treated using, this happened during cortical washing with the BSS at the end of the surgery before the IOL implantation. So in that series, the etiology of intraoperative hard eye was very clear, and they just use a pars plana aspiration of the aqueous which had gone behind, and the patient had done well. So basically, I would like to conclude by telling that you must detect the conditions that may predispose to intraoperative hard eye. And in this situation, I had a patient with angle closure glaucoma, hypermetropic eye, another patient with multiple injections in the posterior segment, hardish cataract. Though my rhexis was not small, so make sure that you take all the preventive measures. If you make a small rhexis in the setting of a hard cataract, you may have a rhexis block, and that may break the posterior capsule. So this was, I think here the posterior capsule is more fragile. Cortical cleaving hydrodissection should be very carefully done. You must burp the anterior chamber, the ovid out of the anterior chamber. Control injection of BSS because the posterior capsule is fragile, as I've been alerting you, as I've been telling you, and be alert to the pupillary snap sign. As soon as you detect a snap, you take a decision what you should do. Most of the time, you would like not to continue with phaco, but convert to a small incision, manual small incision cataract surgery. So you have to quickly consider the differential diagnosis of intraoperative hard eye, And if you think in terms of supracortical hemorrhage, you must postpone the surgery further. And in certain situations, I have just before IOL implantation, when the eye has become very hard, I have used IV mannitol and taken out the patient after a couple of hours. You may even postpone the surgery and take out the patient on a different day. And a limited pars plana vitrectomy also can be done, as was done in my first case, in case where just before IOL implantation, when the eye becomes hard. So that is one of the methods of doing it. Thank you very much for your attention.
Thank you, Aru. Just a quick question. In aqueous misdirection syndrome, does mannitol work at all?
No, it is not going to work. I thought in terms of some in the first case, angle closure glaucoma, maybe some suprachoroidal effusion. So that was the reason I started off the IV mannitol, and that is precisely the reason we use IV mannitol. In these cases, it shrinks the vitreous to a large extent. But if you have thought in terms of aqueous misdirection syndrome, it's a different etiology. So I mean, it is if you just postpone the surgery by a couple of hours, or you take up the patient the next day, you find that eye is very small.
Actually, I've seen some of them developing aqueous misdirection post-op also in these angle closure glaucomas. I don't know if you've seen that.
Post-op?
Yeah, post-op, meaning immediate, not even a day later, maybe a few days later, they come back with suddenly a very hard eye. And then the only thing that seems to help is to break the, do a YAG and break the anterior hyaloid.
That would be malignant glaucoma.
Yeah, so malignant glaucoma is aqueous misdirection, isn't it?
Yeah. I think we can move on to the next presentation.
Yeah, Dr. Suvira, please go ahead, Suvira, on zonular dialysis during PECO.
Screen share. You have to go to screen share. I know. Yeah. Okay, start. Here are a few cases of an intraoperative zonular dialysis and the way in which they are managed. What? Sorry?
The audio is a little muffled.
Can you hear me?
We can hear you. It's a little muffled.
Shall I try? Can you hear me now?
Yeah, it's okay now.
Move the mic a little closer.
It's
come a little closer. Here are a few cases of intraoperative zonular dialysis and the way in which they were managed. Now, dealing with the preoperative zonular dialysis is a planned event where the surgeon has enough time to evaluate the extent of the zonular dialysis, either on a slit lamp or aided with a UBM, can have a strategy in place. Both the patient and the surgeon know what they are in for, and you're likely to know what the results could be like. Now, this differs from an intraoperative zonular dialysis, which is completely unplanned, catches the surgeon by surprise. He almost never can tell what is the extent of the zonular dialysis. Intraoperatively, a new strategy needs to be put into place, and for all the above reasons, you may sometimes have a compromised end result. Let's see a few such cases. Now, this patient with a pseudoexfoliation and phacodonosis is a good candidate for a capsule tension ring. After achieving a pupillary mydriasis and making the rexes, the surgeon now introduces a suitably sized CTR with a hand-on maneuver in through the main incision into the capsular bag. The trailing eyelid is hooked on with a Sinskey hook, which is rotated into its position in the subcapsular base release, giving you a nice amount of zonular stability. In this case, while attempting to remove the last fragment of the nucleus, the surgeon notices a downward flap of the superior capsular bag, signifying a zonular dialysis. He attempts to put in some viscoelastic, which actually makes the zonular dialysis worse, and there is a vitreous disturbance. The surgeon now introduces a CTR, and as you can see, it progressively goes in, and there is a progressive opening out of the bag. The trailing eyelid is hooked onto a Sinskey hook, and it is rotated into its position and disengaged with a spatula from the opposite side. You can note that there is a peaking of the pupil, which signifies managed with the help of small Barnard scissors, and at the end you have a nice round stable bag and a nice round pupil. Now, while attempting epinucleus removal in this particular case, the surgeon notices linear folds in the underlying capsular bag for which he performs a viscofluid exchange. The CTR is then introduced again through the main incision in a hand-on-hand maneuver. This technique of introduction of the CTR is the linear circumferential delivery of the CTR in the capsular bag. The trailing eyelid once more is introduced into the eye. It is rotated. Its disengagement is such that both the open ends of the loop should be away from the subluxation. Here, while doing irrigation aspiration, the surgeon performs a viscofluid exchange, and then once more a CTR is introduced into the capsular bag. Please note that the introduction of the CTR always has to be from a point away from the zonular dialysis to then make the zonular dialysis worse. And at the end, you've got a nice stable bag. At the end of phacoemulsification, this surgeon is introducing a single piece lens but pushes down backwards on it, resulting in a rotation of the IOL, and it is brought into such a position that the haptic goes and sits against the weak area of the zonules, giving you a stable bag. This seems to be uneventful phacoemulsification. At the end of nuclear emulsification, the surgeon removes both the instruments from the eye, only to find that there is a zonular dialysis superiorly. The bag is insufflated viscoelastic, and the surgeon now again puts in a CTR. It's always important to note what is the angle of entry of the CTR. Something too shallow would it make it end up in the angle. Something too deep would make the CTR come back out upon itself. Now, in this case of grade 2 nuclear sclerosis, after a successful second chop, you can see a failure to disengage the probe resulted in a zonular dialysis. The CTR in this case is introduced with a fishtail technique, which is a safe, effective, easy to perform, zonule-friendly technique, which now no longer requires a circumferential delivery of the CTR, which has its own inherent issues. So how is this technique of a fishtail CTR? How is it done? A CTR is taken, it is bent, and the bent CTR is held with a pair of forceps. The apex is introduced to an unenlarged main incision and then under the lower rhexis edge. Then, turn by turn, each of the eyelids is engaged and slipped into the eye and introduced under the corresponding capsular bag. Without needing to do a linear circumferential delivery of the CTR, it becomes a fairly safe method of putting in a CTR. Now, the use of an injector to inject a CTR for an intraoperative zonular dialysis is great because it allows for ease of delivery because we're injecting exactly at the same plane of the capsular bag. Now, here's a patient with a grade 3 nuclear sclerosis, and after performing 2 chops, the surgeon notices that the bag is subluxated, which is not allowing the nucleus to turn. Attempts to put in a CTR, but halfway down the introduction of the CTR, or the attempt to do so, there is a resistance in the further introduction of the CTR. In fact, there seems to be a tipping backwards of the lens, which means it actually made the zonular dialysis worse. The bag is now supported with a capsular hook, giving it vertical stability, after which the surgeon completes the introduction of the CTR into the capsular bag. With ease and care, is now able to complete the nuclear emulsification, the irrigation aspiration, and the introduction of a single-piece lens. Yes, we did not have a 3-piece lens. I would have preferred to put in a 3-piece lens supporting the capsular bag at 2 o'clock. But once this was done, the end result is fairly satisfactory. So what really is my learning? When you're dealing with a patient with an intraoperative zonular dialysis, the mere adding of capsular hooks to support the capsular bag and no CTR is a little dangerous because we cannot always tell what is the extent of the zonular dialysis. So even if you do a very careful slow motion phaco and only have used hooks and the subluxation be large, as was in this case, the entire capsular bag is just absorbed at the end of the nuclear emulsification. So what would be a safer bet? Yes, you go ahead and use capsular hooks to support the capsular bag to give you a vertical stability. But in addition to that, prior to nuclear emulsification, it is important to introduce a CTR to give you a circumferential stretch of the capsular bag and no longer make it endangered for the probe to accidentally pull it out. With ease and care, then the surgeon can complete the rest of the nuclear emulsification. Now, this patient with a grade 2 nuclear sclerosis ended up with azonular dialysis, for which you can see a CTR being introduced with a hand-on-hand maneuver. The point to be noted in this particular case is that ever after you've introduced a CTR, if you can see any of the edge of it, it actually signifies that you've got a subluxated bag and it's not adequate support. In this case, additional support was provided with the scleral fixated Emmett segment. Now, this Emmett segment or the axillary tension segment can be introduced even into a phakic eye in order to stabilize a subluxated capsular bag. So what you can do is put in the capsular tension segment through the main incision, keep it at its proposed site of fixation. The eyelid is hooked on with the help of capsular hooks introduced via the limbus, and it is pulled out, which gives you a large quantum of vertical and circumferential stability, which allows for ease of emulsification. At the end of the surgery, after the IOL is in, you can scleral fixate these. And this is the last video. It's really hardly any time for this, that you can take 2 needles connected to a tenoproline suture. It is passed through the eyelid of a CUS into the capsular bag at the proposed site of fixation, and 2 needles, each of the 2 needles, turn by turn, is railroaded and exteriorized to come to lie at a point 1.8 millimeters behind the limbus in a grooved scleral tunnel. Once the 2 needles are exteriorized, so you have the needles which have gone through the eyelid and both exteriorized at the proposed point of fixation. Both the needles are cut and the suture ends, which are now long, are pulled out and they are tightened, and the extent of tightening is just adequate to give you a good centration of the IOL. With that, I come to the end of my presentation. Thanks, Sudeep, very, very much for me and part of your team.
Thank you, Suvira. Perfect timing and great presentation. We have Dr. Meenu Martin next. He will be speaking on hair raising situations during IOL implantation and also on wound burn. Go ahead, Meenu.
Can you hear me, Dr. Sudeep?
Yes, very clearly.
Thank you very much for the opportunity. So I'll talk on hair raising situations during IOL implantation and some part about wound burns. So I have no financial interest in this presentation. So let's see this case by a trainee. You can see a huge piece rent nasally, and the IOL is getting implanted. And especially in young people, they are surgeons, they are a little upset now. So the IOL directly goes into the piece rent itself. So instead of trying to catch it, it is being pushed further back into the vitreous. So this is a heartbreaking kind of situation which can happen to anybody. But I would say when you have a piece rent, use a 3-piece IOL, place the haptic and the optic inside first and leave the trailing haptic outside, and then dial it in carefully so that it goes into the sulcus. So here again, after implanting an IOL, we should carefully inspect the IOL as a whole. You know, it should be in the bag. You should inspect the optic, the haptic. Sometimes there may be cracks inside the haptic-optic junction, which may be hiding. You know, sometimes you will not realize. So inspect the implant very well. Here is a lens which was implanted into the bag and is well stuck there. The optic is well centered, but later it presented with the decompensated cornea because the haptic broke off, came into the anterior chamber, got stuck to the cornea, and it was decompensating. So this is the importance of inspecting the implant while it is going in and after the IOL is inside the capsular bag. Okay, we will just see this 3-piece IOL going into the capsular bag. See, it is facing towards the right. So that is the thing which we should avoid. Please focus on this area. You can see the haptic swing from one side to the other. So always in 3-piece IOLs, we should make sure that the haptic is opening towards your left in the leading haptic always. Otherwise, it can swing from one side to the other and tear off the posterior capsule, especially if you have some visco leaking out. So please watch this IOL being implanted.
So if you notice, it went in like a rocket. That's because of some problem within this injectors. Then you have some overriding of the tip on top of the optic. And then you can notice it has gone further across the midline and gone. So definitely there is either a zonal dialysis if it is the sulcus. This is in the bag, and so it has gone in to the AVF through the equator. So the pupil is not well dilated, so you can't see it, but I retract the IOL and place it back 90 degrees away from the area where it went into the AVF. But now what I do is I retract it and check, and without me knowing, I'm pushing the IA tip also along there. You know, see when the IA tip is being pushed along, see it has pulled out some vitreous. So this is something which you should avoid. See, if you don't see vitreous, don't irritate that area, leave it there, and then aspirate the visco from somewhere. See now you can see the periphery. There is a piece around there in the periphery. So after you place it, look for vitreous. If you are not very clear, use triamcinolone acetonide and identify vitreous and do a vitrectomy. Here I had to just do a little bit of vitrectomy and everything was fine. So look at this one. When we inject, you will realize that once the optic is coming in, this haptic is not coming out. So this is a leading haptic. Once this haptic is not coming out, then the whole thing is a problem. So either it is in between the cartridge tip and the injector tip, or it is within the flaps of that butterfly injector. So now if more than half is not gone in, means you can even retract. 1/3 of it is gone in. But if more than half of it is opened inside, you can't do anything. You have to let it in free into the anterior chamber. Once that is in, you see only 1/2 of one haptic here. If it is left in the bag, it will decenter. So push sodium hyaluronate in the bag, get the IOL in the anterior chamber, get another proper IOL placed into the capsular bag, and explant this IOL. So here, I do not use any other lens cutting instrument, although it can be used. This is a long Vanna scissors, which is kept separately for these kind of situations. I buy it from Appasamy and I don't have any financial interest in this, but it cuts any of the IOLs which are available now in the market. Once I like cutting it in half so that it comes out through a 2.8 to 3 millimeter incision very easily, because I don't want to squeeze out any IOL through tight incisions and make the incision worse. So once it is rotated in position, catch it well and bring it out, and this ends the case well. So in this one, this is a femto cataract. So if you notice the rexus here is complete. This is a complete rexus. So here again, same thing happens with this kind of IOL. So if you notice this is the position of the tip of the injector, and the IOL edge's tip is here. So this tip should have been here, and that is why it is overriding the optic and causes thickening of this. The whole thing is more thick, and you need to apply more pressure. And once you apply more pressure after the bottleneck is over, that pressure is too much and it fires the lens inside. This is what happens. So inspect your injector, see whether the bend of the tip of the injector is reduced. If it is flattened out, do not use that. So here you can notice very clearly that luckily, although it went into the bag, it has broken the anterior capsule margin. So this also can happen. Retract the iris and see here this discontinuity. So this has not extended into the periphery or onto the posterior capsule, but this can also happen. So this is one case. See, this is what we have to make sure. To the sides, there are grooves into which the tip of the optic should be tucked in along with the haptic tips. That is how it is well loaded. So this is well loaded, and this hydrophilic acrylic IOL goes into the bag. See, notice haptic goes, optic goes. Suddenly there is some resistance and there is a giveaway field, and the haptic is engaged here. It's not coming out. And if you notice, I pull back and see the injector tip has cut through the cartridge, and the plunger tip has come out, and the haptic is entangled between the tip of the plunger and the nozzle. So here we have to slit open the nozzle. It should be the tip of the haptic, which is entangled here, should be avoided, and another area can be cut. And when you come towards this area, it can be cut more.
Minu's frozen. Something to do with Minu's connection.
So the next one. Sorry about that. Okay, so here comes another case where everything is fine. PC is fine, anterior capsule is fine, IOL is in the bag, well set. It is rotated in position, haptics open, I aspirate the visco from behind, and once I try to tilt the lens and aspirate, I see some lines on the PC. So this is when you have to stop and think what has happened. These two lines were not there. So everything was fine, but so I'm trying to inspect. See, this is loosening up, and you find that it is just a bit of long thread of cortex, which is stuck to the haptic and the optic, back of the optic. So sometimes you may be fooled. You may think that it's a PC rent and you may explain the IOL and all. So inspect properly and identify. So with this kept in mind, if you see this case, this is a mature cataract and just showing you that the rhexis is complete and the whole lens is being emulsified. Now the emulsification is complete. The cortex is also aspirated. By the time the pupil becomes slightly smaller, but the rhexis is fully intact, and then goes the single piece acrylic hydrophobic IOL into the bag. So while I inject, push a little bit harder. You know, see, it goes into the bag, and suddenly I notice that there is a line here. So this is inferior, and I complete my cortex aspiration. There's a little bit of cortex there. Still, I thought there is some line there. That's okay. It's a fold. So sometimes when IOL goes inside, you get a fold, but this fold is not moving and it's remaining stationary. And now I retract the iris properly and see, and it's a huge posterior capsule rupture which has happened. So here I'm introducing a little bit of phenocane and dilate the pupil as much as possible, and then put in sodium hyaluronate, fill up the anterior chamber. It is decentering. So this lens has to come out. So this is being dialed out of the bag. There is no vitreous disturbance as of now. So the visco is going in and pushing back. You have only ruptured the posterior capsule, and it is being dialed out now. So once that is dialed out, like what we saw before, we can implant a 3-piece IOL into the sulcus. So anything can happen till the end of the case. So during IOL implantation, we should not be complacent. We should not think that nothing is going to happen. So there can be so many situations where you can lose the capsule and you may not be able to implant the possibly promised IOL to the patient. So we'll move on to the wound burn, which is a little uncommon nowadays, but we used to happen with the lower end machines, and when we used to use a lot of energy. So we'll be happily phacoing away things. And just after taking out the handpiece, you'll see this kind of whitening at the incision. So this is a very small burn here. So it may extend further till the cornea, and it can be very bad. It can cause shrinkage, all those things. So what I want you to notice is the mismatch of the incision and the sleeve. So always see what is recommended by the company people and use that kind of a keratome. So you may be using a 2.2, but the company would have given a 2.4. So we'll squeeze in instruments through that and see. This is where I want you to take a look at the incision here. This is a little tighter. So you'll see that the sleeve is little tighter within the incision, and that will affect the fluid flow and the heat dissipation. So another point is that when you are inside the anterior chamber, if you have filled it up with the OBD, like dispersive heavy OBD, please aspirate most of the OBD above the lens before trying to phaco the lens, because that can again block, and that is also thermogenic, and it can extend the heat onto the incision. And here another point is to note the movement of the tip in the sleeve. So if you keep it straight, it's fine, but unknowingly we might move the needle towards the side. See, the whole thing is moved towards the sides, or you may lift up or you may push down. All those situations, the fluid will not flow in between this area, and the heat will be directly transmitted onto the incision, and you will cause phaco burn. So keep looking at the incision also occasionally while you are phacoing, especially when you are doing harder cataracts, and do not use continuous energy for a long time. And when the energy is required, please use judiciously and use the modulations which are available, like burst modes with a lot of off time, and pulse modes with a lot of off time, so that you get less of heating up of the incision, use less of energy. And also the tip, when it gets blocked, when larger pieces are being taken, it may occlude the tip, and you continue doing phaco. There is no fluid inflow and outflow, and the heat generated is transmitted. And so you listen to the sound from your machine. If it gives you that ting 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 sound, it means that your tip is occluded, and stop phaco, don't do phaco. And as I said, the needle position inside the sleeve. So whatever happens, finally, it has to stop leak spontaneously after hydration. If it doesn't, 100% suture. So horizontal suture is also good. You can include that small burn which you saw there, even if the large one. Take a bite through the floor, come up onto the roof and take another bite through the roof, and within the incision you can tighten. And after hydration, spontaneously it should not leak, and also on pressure from some other side of the limbus it should not leak. If it leaks, put sutures. Even a 2.2 incision may need 2, 3, 4 sutures. So astigmatism may be huge, but do not care about that, because you will end up in a situation of a chronic leak and the chamber shallow and an endophthalmitis risk. So closure is the first aim, and multiple sutures so that the incision is watertight at the end. Air should not be put, because air will stop the leak, but it will be leaking once the aqueous forms again. Here again, it is not stopping, so I put another incision, another suture, and then only it closes. So with that, we come to the end of this, and thank you very much.
Thank you, Menu. Whenever I see Menu's videos, I realize how important it is to record all your surgeries. Only then you'll end up with videos like this.
So the one question, you were showing a 3-piece multifocal. No, which company makes that?
That is Technis, the old Technis.
Technis.
It's still available.
Fine.
Still available. So next talk is by Dr. Suvan Bhattacharya on intraoperative meiosis and iris prolapse.
Thank you, Sudeep. Thank you for this opportunity. Can I share my screen?
Yes.
Yeah. So you can see my screen now, and can you hear me clearly?
Very much.
Yeah. Thank you. So thank you, Sudeep, for this wonderful opportunity and for having this lovely course every year. So I'll be speaking on intraoperative meiosis and iris prolapse, basically IFIS. Rapid or not, it's always IFIS. I'm Suvan Bhattacharya, and I'm the inventor of the BHEX, and I have a financial interest in med devices. I acknowledge the contribution of Dr. Deepak Magur for one of my videos over here. So intraoperative meiosis and iris prolapse, the spectrum ranges from mild to severe, where mild is only iris billowing, whereas with good pupillary dilation, whereas severe is iris billowing and a poor pupillary dilation and iris prolapse. Now, I was fortunate that ASCRS mailed this wonderful video of mine in 2013 to 30,000 ophthalmologists worldwide, based on my IC presented at the ASCRS in San Francisco. So let's take a look at this video. So this is a case of, the different cases. So the first one is where you see just billowing of the iris or undulation of the pupillary margin. And that is, we have a fairly reasonable pupillary dilatation. So that is nothing to worry at this stage. This is a case which is a classic IFIS. As the anterior chamber is inflated, the pupil dilates, and with no reason whatsoever, the pupil again comes down. And I'm having difficulty removing that chopper, and we have iris prolapse already. Now, again, when I inject viscoelastic into the anterior chamber, the pupil dilates. That's a typically elastic pupil of an IFIS. So there again, I'm saying nothing wrong with my flow parameters. This is perfectly all right. But this is a very old video before even we recognize IFIS. Actually, I pulled it out from my archives. So now this is a very good technique to reposit the iris. You just decompress the anterior chamber. That's very important because you keep injecting and the iris will prolapse. And here we have iris prolapsing from both the side ports. Not a very happy situation, but still the pupil is reasonably good, where we can dilate, but when we inject viscoelastic, the pupil dilates, so we can happily finish off the case, and that's the undulation of the iris at the end of the surgery. Now, this is a case which was a nightmare. Now, I saw IFIS right in the beginning, recognized it, and put iris hooks, but then before I could finish my capsular access, the iris was tattered totally. So now I'm struggling with that phaco probe. I might cause an iridodialysis because the iris is going to get engaged over here. The good thing is to use that side port instrument to kind of release the iris and protect it as the phaco probe advances or any instrument advances into the anterior chamber. Now now it's my turn to struggle with that largest chopper that I am having. It's a hardish cataract, so I want to use a large chopper. So inject viscoelastic, create space, and you can see that patulous iris bowing like a sail. And now I have an iris knuckle in the incision. I really can't do much about it. But then fortunately, we have a good dilatation. That's what the devices provide, is they provide a safe dilatation to complete the surgery. And now it's time for the IOL. And again, I'm worried that I might engage the iris, the frayed iris. So again, I protect it. And now once it's past the iris, I can easily inject that IOL into the bag. And now I deposit the iris and from all the ports. And a good idea is to use change your angle of attack and kind of use a side port to deposit the iris from the main incision. You can see it's looking like a fishing net. And now that I've done that, I choose to hydrate the incisions. And unfortunately, as I'm hydrating, the iris again prolapses. As soon as the antechamber pressure increases, the iris will prolapse. Well, I go ahead and kind of hydrate that incision further. And then, because once it's sealed, the iris will not prolapse. Once I've got a seal, now I can again pull that iris back and we are in a happy situation. So this looks pretty good now. Let's look at intraoperative masses and how the BHEX can help. So this is a hard cataract, and halfway through the surgery, or actually when I've just about finished half of the cataract, a heminucleus is left, which is pretty hard. And with that kind of a pupil, I'm not really encouraged to go ahead. So now, this is because of probably some amount of nucleus. So now we inject viscoelastic over that capsular rim to create space for the BHEX, and then take that first flange and tuck it under the iris. Now, note how easy it is to identify that you have not engaged the capsular excess margin. There, as you push it, advance it towards the periphery, you have instant confirmation that you have not engaged the capsular excess margin. Again, as you engage, it's under direct visualization, and you have so much control over that flange that even if you engage the capsular excess margin, you can refract. You cannot do that with other devices. So once you have that 5.5 millimeter pupil, you are in the safe zone, you are back to your comfort zone, and you can finish off that phacoemulsification with ease, however hard that cataract is. It's just that 5.5 pupil that you require to complete the surgery. Now let's see what's the difference between the Mulligan ring and the BHEX. The gaps in the scrolls are not visible from the top view in a Mulligan ring. And if you do engage the capsular excess margin, it's a disaster because it's a continuous process. Now, in the BHEX, the gaps and the notches are clearly visible from a top view. And even if it engages, it generally engages the pupil margin with certainty. If it engages the capsular excess, you can still kind of disengage it. Now, this is a video from Dr. Deepak Magur, a wonderful video. So, well, even at this stage, he's not contemplating using devices, starts the phaco, but then it's a pretty hard cataract. Well, now it's time to choose a device. He chooses the BHEX. So a little bit of viscoelastic over the capsule. Let's look at the ease with which the flanges are tucked under the capsular excess margin without engaging the capsular excess. So there you have, once you are comfortable with that pupillary dilatation, you can go ahead and finish the surgery. So can the preoperative pupil dilatation be used to predict IFIS? So this is a paper in 2011, JCRS by Alessandra Cassuccio and co-workers. The conclusion was for a pupil 7 millimeters or smaller, the risk of IFIS existed regardless of alpha blocker antagonist or alpha blocker treatment. So is IFIS a problem in India? Well, turns out that it is, and it is a bigger problem. Prevalence of tamsulosin intake and IFIS incidence is higher in India. And guess what? Tamsulosin, alfurosin use, and hypertension are very important risk factors. I mean, about 60 to 70% of our patients are hypertensive. So that's the list of drugs which can cause IFIS and systemic conditions like hypertension, chronic heart failure, and diabetes. So no amount of history taking can prevent surprises. And intraoperative masses is unpredictable. So let's be very clear about that. Now, this is a case, well, you can use your judgment and let me know, was it too early to use a pupil expander device? A pupil with just 5.5 nucleus cataract grade 4, planning a toric IOL, hypertensive patient, a short eye, and a shallow antechamber. Let's look at this. So we've done our markings. A pupil is, I mean, not very small. If it were not for a shallow AC and the kind of signs I saw here when I was injecting viscoelastic eye kind of coming out, I noticed a flicker of iris prolapse. So I said, no, I'm going to do a BHEX. Now this looks very harmless. In fact, it looks as if it's useless. Now look at that iris prolapsing from the side port. The side port is not large. It's only because the iris prolapse is looking big. And now you see the iris is prolapsed from the main incision. So these are the eyes which are prone. And if you have a hint of iris prolapse in the beginning, it's better to take that call early. I do manage to, there again, a device always provides you good pupillary dilatation for safe phacoemulsification. It may not prevent iris prolapse, but most of them don't. I'll be coming to that. So devices have got nothing to do with prolapsing it. Now, this is where the BHEX is a huge advantage. I can take it in a prolapsing iris. You can take it out through the side port. I have to be careful not to touch the endothelium, but then I can disengage those flanges and take it out through the side port. No device, no pupil expander can do that. And that's a huge blessing when you have a situation like this. So post facto, how many would have of you would have used the iris hooks or pupil expander? So it is important to take that call early, but before you are in a mess. So BX is probably the only device which can be removed through a 1 millimeter side port, and that is a huge advantage in when you have iris prolapsing through all the side ports and the main incision. So my choice of pupil expander in intraoperative masses, either iris hooks or a BX. Iris hooks also pretty good if you're happy with putting 4 incisions, as long as you don't over retract. But you must remember that neither iris hooks nor the BX will, or any device for that matter, will prevent iris prolapse. I'll come to that. Now, which is the best device? If you ask me, iris hooks, pupil expander, among all the pupil expanders. So let's take a look at this objectively. Now, you have 2 components over here, meiosis and iris prolapse. For the meiosis component, whether you use iris hooks or pupil expander, what they do is they provide a constant pupil size, which allows good visibility for safe phacoemulsification. That's fine with both the set of devices. For iris prolapse, actually no device helps. Iris prolapse depends on the severity of IFIS and the pathological damage to iris stroma and muscles. So there is no credit to the pupil device when you don't have iris prolapse. It's just lower grade IFIS. Remember that. Just because you got away in IFIS in one case with one device, it will not happen in the other. So a favorable pupil expansion device in IFIS is which requires small incisions, has a low vertical profile, can exit through the side port, and I think iris hooks and BX qualify very well for that. So the lessons that we've learned in these cases of IFIS is there is a host of systemic conditions that could cause IFIS, and hypertension is unfortunately an important risk factor. And patients with pre-op pupils of even 7 millimeters are at risk, irrespective of alpha blocker treatment. It is also important to remember that tamsulosin may be used for urinary retention in women, and they may absolutely be unaware of that. As I said, iris hooks and pupil expanders, they do not eliminate iris prolapse. They may reduce the intensity of iris fluttering or prolapse, but they do maintain a dilated pupil, providing visibility and safety, and that is where their role is. So every eye is an IFIS candidate. We need to reduce our threshold for using pupil devices and keep yourself well stocked in your theater. If you're interested in reading this more about BX Pupil Expander, tips and tricks, this is a wonderful PDF which you can download from the website. The page is medinvendevices.com. The page is BX Pupil Expander, subpage ophthalmic surgeon. You have PDF, the video links over there running along the text, and when you click on it, you get to the exact scene. And if you want to read something on phacoemulsification in small people, I have penned an article in eophtha.com. I'd encourage you to take a look at that. Thank you once again for your kind attention, and thank you, Sudeep, for this opportunity again.
Thank you, Suben. Wonderful as always. Next, I invite Dr. Subhendu Goral for his presentation on something which is not that common now, but we do see it. I think I saw one in a routine phaco a couple of years back, expulsive hemorrhage and suprachoroidal hemorrhage.
Thank you, Sudeep, and thanks AIOS for for keeping us all together in this virtual forum. Like so, now this is how the suprachoroidal hemorrhage can all of a sudden can happen after kind of like inadvertent ICC. You can see the intraoperative suprachoroidal hemorrhage, courtesy Dr. Subenda. So suprachoroidal hematoma and suprachoroidal effusions, my drainage techniques. So it is a rare condition, as Dr. Sudeep Das told, that it is a rare condition defined as a collection of blood in the suprachoroidal space in between the sclera and the choroid. And the incidence varies after ocular surgery, 0.04 to 1%, and the potential space between the sclera and the choroid, that is the suprachoroidal space, is actually a virtual space, and normally it contains approximately 10 microliter of fluid. So predisposition factor reported for the development of suprachoroidal hematoma, if you consider advanced age, glaucoma, increased axial length, high incidence in myopic patient, and patient have a systemic cardiovascular diseases like hypertension, diabetes, non-phakic status, and history of vitreous loss during surgery, as well as in the suprachoroidal effusion that may be from after surgery, post-operative, like in glaucoma surgery, in TRAB 1.4 to 2%, or glaucoma drainage device to 2.7 to 8%, or from the neoplasm or inflammatory condition of the eye. So intraoperatively, just after removal of the cataract, signs of intraoperative supercharged hemorrhage should consider always the bulging forward of the iris diaphragm, vitreous starts swelling out of the limbal section, iris collapse out, what was discussing in previous talks, that collapse of iris. So sipping or prolapse of the vitreous through the wound, or easy breaking of the sutures while closing the wound. So primary in management for suprachoroidal hemorrhage or effusion, if we have to tightly close the incision, posterior sclerotomy at that infratemporal quadrant, and anterior sclerotomy either 1 or 2 10 to 12 millimeters posterior to the limbus on either side of the superior muscle, easy to perform. So these are the situations, so indications for the surgical drainage, when to drain the suprachoroidal hematoma after surgery. You have done the cataract, but inadvertently suprachoroidal hematoma happens. So when there is extreme pain, persistent flat anterior chamber, uncontrolled elevated intraocular pressure, retinal detachment, central choroidal effusion, and retinal vitreous incursus in the wound, or inability to deposit the intraocular contents. So postoperatively, any time up till 2 weeks, it may happen. So ideal time for drainage, you have to wait for the clot lysis. Otherwise, the adequate clot lysis may not happen in cases of suprachoroidal hematoma cases. If it is effusion, anytime you can drain it. But if it is like hemorrhage, you can see the black glow or dark glow, or you can see the hematoma-like situation, or you can by clinically or by ultrasonography, you can detect it is not effusion, it is hemorrhage. So it is the timing is ideal 7 to 10 days. For secondary management, you have to refer it to the VR colleagues. So this is how we are doing the it is a short animation after doing vitrectomy and injecting PFCL, and through the 23 gauge or 25 gauge non-valve cannula, you have to drain, you can drain the suprachoroidal blood. So coming to our practical situation where there is retained lens matter and you can see the encasing almost like casing choroidals, and you have to do the lensectomy and do the vitrectomy after clearing the vitreous. You can see the suprachoroidal hematoma is there. So this is the in a sutureless manner, we are draining the we are introducing trocar cannula obliquely into the suprachoroidal space and removing the trocar blade, and then after doing vitrectomy, we are injecting PFCL push from inside and suprachoroidal blood drainage from outside. You can see the tip of the cannula to the suprachoroidal space, and at the end of surgery, remove the PFCL and inject the silicone oil to have a constant endotympanotic action. Postoperatively, you can see the vision improved to 6/60. We have done the silicone removal. Ultimately, patient gained 20/200 vision. This is another case. ACIOL implantation was already done during the surgery, but there was hematoma and casing choroidals. So even during the introduction of trocar cannula, you may face the drainage of suprachoroidal blood if the blood is extending towards the choroid, or it is towards and very much anterior ciliary body. Like now, you have to drain the suprachoroidal blood, introducing trocar cannula complex obliquely into suprachoroidal space according to maximum height in the ultrasonography. Then you can see injecting PFCL from inside, and external passive drainage of the blood is possible. It is not mandatory to remove all the blood, because some blood may get absorbed after in postoperatively due to the natural process. Like postoperatively, you may get good picture, but silicone removal not done because of hypotony even after 6 months of surgery. This is another case of suprachoroidal hematoma in 2 quadrants. Suprachoroidal blood was there, and there was hyphema. I am using AC maintainer and then draining the suprachoroidal blood from the from the space using multiple non-valve trocar cannula, 23 gauge trocar cannula, removing the trocar blade, and then cannula guided drainage of the suprachoroidal blood was possible. After doing vitrectomy, injecting the PFCL push from inside and external passive drainage of black colored, you can see dark colored blood is a suprachoroidal blood. It's not it's altered blood. So it's a quite liquefied blood, but still some blood was there. Then I removed the PFCL, injected silicone oil. At the end of surgery, after 3 months of doing the surgery, I have removed the silicone oil and planned for the gluteal implantation in this case. So if the AC support is PC support is not adequate, so you may plan for the scleral fixation of lens, either glue or glueless, sutureless scleral fixation of IOL, and patient finally gains 6/9 vision. So another this is, you can see the upper gluteal surgery nicely retina is attached, and the suprachoroidal blood is totally resolved. Although the residual blood was present during the surgery, at the end of surgery, But you can see during the silicon removal, it was not there, and patient is absolutely fine. Vision finally gained 6.9 vision. This is another case, hemorrhagic kissing choroidal total retinal detachment. Sometimes suprachoroidal blood is not that much, but presence of retinal detachment, it may appears to be it's a quite huge color, huge amount of blood is there. So that just see, I have I did the vitrectomy and there are small anterior breaks, so I can see the disc here. So I have to inject the PFCL to for the drainage of the subretinal fluid, internal drainage, and after adequate drainage of subretinal fluid, then you can judge, you can assess the actual amount of suprachoroidal blood along with it is not that much, not that kissing choroidal because of the bullous character of the retinal detachment. It seems to be very much like it is suprachoroidal kissing choroidals. Now complete your vitrectomy and do vitreous base excision and drain the blood using the trocar cannula. This is injecting, then remove, then settle the retina and do laser. At the end of surgery, you may use silicone oil, or you have to use the silicone oil because of it is giving the constant endotamponade effect. And postoperatively, you can see the good result. So it is another case of hemorrhagic kissing choroidal total detachment. You can finally you can see the residual choroidal blood is there. Still, patient gained some vision. So another case, vitreous hemorrhage suprachoroidal blood, and finally patient gained 6/36 vision. So, so in this another case, total choroidal incarceration was there, but patient I have not removed the oil because of chronic hypertony, and vision was not that much logmar vision, although the hemorrhage was resolved not completely. So another is the bad prognosis case, retina incarceration, retina detachment, suprachoroidal hematoma. These are almost non-visible cases, but still retina appears to be okay, flat. Silicone was not removed because of chronic hypertony, because oil is just preventing the crisis valve-like condition. So better prognosis cases, say CH involving only one or two quadrant. Poor prognostic factors or presence of retinal detachment, kissing choroidals, or retinal incarceration. So take-home messages should be suprachoroidal hematoma, suprachoroidal effusion. So let me tell you one thing: the suprachoroidal effusion condition are really salvageable after doing this kind of choroidal drainage. You may get good results, 6.9 postoperatively after glaucoma surgery. But suprachoroidal hematoma, these are the things. If it is one or two quadrant, you may get good result. But if it is definitely you will get good result after the drainage socialistly, but using multiple cannula posterior drainage. But if it is associated retinal detachment or it is associated retinal incarceration, these are the very poor prognosis factors. So you may not get good vision, although may have a try, patient may gain some vision, but not ambulatory vision, not even ambulatory vision. So posteriorly made sutureless sclerotomies are really helpful. Multiple cannula drainage is possible to drain the blood as much as possible. PFCL is helpful to push it from the inside for adequate drainage, and use of silicone oil can give constant endotamponade. Definitely prevents a deep bleed as well as maintain the intraocular volume, and you can maintain the intraocular size of the voice. So far we have managed 15 cases of suprachoroidal hemorrhage. These are the results. So thank you for your patience hearing.
Yeah, thank you so much. I'm surprised at the color of blood. It's absolutely black. It doesn't look anything like blood.
Okay, yes. Yes,
the blood that comes out of the suprachoroidal space, it's so black.
Yes, sir.
Minu, any reason why you do not use any of those other specialized cutters? I mean, I also use a Vanus for that matter.
No, actually, see, I have cut 3-piece lenses, Technis lenses, even Envista. So, it's working well for me and doesn't go through a 2.2. So I have to definitely make it 2.8. But I have nothing against specialized cutters. They do well. Actually, they are good ones which cut very well. But until now, I have not bought or used it. That's why I didn't find the reason for it, because I don't explant through very small incisions. So I make it 3 millimeters and divide it into 2 halves.
See, another important point is in how to avoid damaging the lenses. So you have to periodically inspect your injector system, the piston, the rod which drives the lens. Sometimes it is not aligned. I recently had a problem with one of those multinational lenses, and then when I saw at the end of the surgery, when I realized that, because of maybe after the lockdown in this prolonged non-use, there's some damage. So before, it is very important that you inspect your injector system very carefully.
No, it's other thing is also, I think, on the make of how you load the lens, depend, because the way you load is different in different companies. Like in Alcon, their Monarch cartridge, you actually have to push the lens down. Otherwise, you'll find that the pusher is going behind it.
I mean, I'm talking about those surgeons who have been using for 15, 20 years,
Yeah.
For a beginner, of course, you need to know the loading technique. I'm talking about even if you know how to load it properly, you've been using a lens, but sometimes the system is not properly maintained, it may land you in problem.
That is true, but I've had certain problems even with the preloaded ones, where you can't actually do anything much. So it's not always perfect. So I've had actually faced that and realized that there's going to be a problem. Then I've somehow taken out the lens from the injector, put it into another injector before it goes into the eye and has problems, and then injected it. So yeah, that's what you're saying is true. Even one has to do that even with the preloaded ones.
So another thing is, moment you find there is a resistance to the pushing the lens, you could not use that lens. You may have to sacrifice the lens. Maybe nothing is wrong, but moment you feel that you are using more than usual force, that system has to be discarded and load a new system.
Other thing is, when do you explant the lens? Like sometimes we see a few scratches, we see sort of a very little crack at the periphery. So what stage do we say that no, this lens has to come out?
No, if the simple 4 or 5 millimeters is okay, I think I'll just leave it alone. And but if there is a peripheral crack and some haptic damage in the peripheral area, I'll just leave the lens alone. But if there is major damage in the optic area, central 3 to 4 millimeters, I have had cases where one acquisition of lens where within the substance of the lens, within the optic in the center, there's a big crack. It didn't extend anteriorly or posteriorly, so I have to expand that lens. So it all depends upon how visually significant that particular pathology is going to be according to your assessment.
And haptics are also important. See, there are the haptics. If it crosses the largest curvature, then it has to go. You look as though it will be centered, but when you aspirate the visco, and then then you will see that it decenters, and so then it has to be explanted. But if the tip is gone, then it is okay. But the rest
also a crack at the optic junction, because when you implant it, there's no capsular tension, so it remains fine. But if there is a crack there, when the capsule starts contracting, the lens will move in that direction because the haptic doesn't have any strength. Thank you. I think we've come to the conclusion of this course. As always, wonderful course. Thank you, all my co-instructors. And we'll hand it over to the next.
We have another 6 minutes left, no? So
Yes, we have 6 minutes.
Okay.
Yes.
Yeah, if there's anything else.
We started before time, isn't it?
Yeah, we started before time.
Yeah, I think we are doing well. We are going ahead of time.
Yeah. We started 5 minutes before time, so that's why you're ending 5 minutes.
Who's the next chief IC? Anurag, is it?
Anurag.
Yeah, Anurag should be thankful to us.
I am, sir, eternally.
Yes.
And you got more than one reasons for that.
We will take our pound of flesh next time.
Just a little camera shy, sir, as usual.
So thank you so much, Dr. Sudeep Das, for beautifully moderating this session, and thank you to all the speakers for their wonderful talks. So I just wanted everybody to give a huge round of applause to this for this session to Dr. Sudeep Das and all the speakers for keeping the conference on time. So maybe for a moment, and let's have a huge round of applause for the entire team.
Yeah.
Done.